So today's topic of discussion is fractures of the forearm. Okay. So before we start off anything, let us come to a small story. Do any of you know what is the meaning of the word orthopedics? First, when I think about orthopedics, the first thing that comes to our mind is the branch dealing with bones, right? But the word orthopedics, it comes from two words basically, ortho and pedics. Sit down, don't worry. Ortho means erect, straight, yeah, and pedics, as you can guess, it comes from pediatrics, this child. So orthopedics has come from the word orthopedics, that means meaning the straight child, erect child. Okay, so the branch first came into existence as a matter of treatment of the crooked child with crooked bones. Okay, deformed babies, treatment of them. From there to here, we have come a long way, right? So let's start a discussion. Fractures of the forearm. So you guys must be knowing better than me. You have just completed it. So forearm is a part of the upper limb starting from the elbow to the wrist joint. Okay. As far as bone is concerned, there are two bones, the radius and the ulna, right? Next, coming to the muscles of the forearm. Okay. So you guys must be knowing we have mainly two sets of muscles. The muscles forming the superficial plane and the deep plane, and sometimes they consider one as the middle plane. In superficial plane, which muscles do we have? The five muscles originating from the middle epicondyle. Okay, starting off with the pronator teres, flexor carpi radialis, the palmaris longus, flexor carpi ulnaris, and the flexor digitorum superficialis. Okay, and in the deep compartment we have the flexor pollicis longus and the flexor digitorum profundus, and lastly the pronator quadratus. Okay, and another quick recap, all these muscles are mainly supplied by the median nerve or its branch, the anterior-inferior nerve, except the flexor pollicis, flexor digitorum, the medial part of flexor digitorum profundus and the flexor carpi ulnaris, which is supplied by the ulnar nerve. Again, these are the muscles of the dorsal compartment of the forearm. These take originate from the lateral epicondyle, right? The muscles are firstly the extensor carpi ulnaris. This is the extensor digiti minimi, the extensor digitorum, so extensor indicis, and the extensor carpi radialis longus and brevis. Okay, and in the deep compartment we have the abductor pollicis longus, the extensor pollicis brevis. This is the extensor pollicis longus, and lastly the extensor indicis. So now let's jump into the main topic, which is the fractures of the forearm. Firstly, we'll be studying about the fractures of the shaft of radius and ulna. Okay. So starting off with the clinical features, the patient will present to you with acute onset pain and deformity of the affected forearm, and obviously since this is a fracture, there will be a history of trauma. Okay, and it is very important that we palpate the radial pulse and examine the hand properly for circulatory and neural deficit. Okay, in case of any fracture of any part of the limb, we should always cross-check about the circulatory and neural deficit. Because if any of these are present, we need to be very cautious, otherwise we might end up losing the limb. Okay. And lastly, we should look out for impending compartment syndrome. Now, what is compartment syndrome? Okay, in case of fractures of arm or leg, even if there is no major vessel injury, there might be a severe ischemia. The cause of this is the bleeding, edema, inflammation. That is the cause of that results due to the fracture itself. It increases the pressure within one of the osteofacial compartments. Okay, and this causes reduced capillary flow, resulting in muscle ischemia, causing further edema and causing greater pressure and more profound ischemia. Thus, a vicious cycle continues. Okay, the earliest symptom that a patient will tell you when developing a compartment syndrome is there will be severe pain or a bursting sensation, which is out of proportion to the severity of the injury. And the earliest sign that we'll find is pain on passive stretching of the affected muscles. Ischemic muscles are very sensitive to stretch. So suppose we have got ischemia of the volar compartment of the forearm. So if we stretch those muscles, the patient will complain of severe pain. Okay. So then, what is the treatment of this condition? The treatment is we need to release the pressure, right? So for doing so, we need to release any kind of external constriction that might be in form of a cast or a brace or anything like that, or even sometimes tight fitting clothings. Okay. So first we have to remove all those external constrictions and let the arm rest in the position of the body. Okay, we won't elevate it or do anything like that. We'll keep the arm resting in the position of the body, and so that the capillary refill can come back. Okay, and if does not help in a matter of 2 hours, we'll have to go for releasing the compartmental pressure surgically. This ischemia causes ischemic degeneration of the nerves and the muscles. The nerves can still regenerate, but the muscle, once infarcted, they result in the fibrous constriction bands, losing its contractility. Okay, so within 6 hours, the treatment has to be started and completed. Okay, if there is any compartmentation developing and it is not helping, the conservative measures are not helping, what we need to do, we need to do a fasciotomy. So what is a fasciotomy? We need to cut open the fascia, the deep fascia, and release the compartment pressure. Okay, and keep it open so that we can treat it later. Next, coming back to the main topic. So what might be the mechanism of injury in the resulting fracture of the shaft of radius and ulna? The most common mechanism is a fall on hand, causing a twisting injury. In case of twisting injury, we'll be finding a spiral fracture of both the bones. The bones will be fractured at different levels. The radius is mostly fractured at a proximal level than the ulna. Okay, if there is suppose an angulatory force, then there will be a transverse fracture of both the bones, mostly at the same level. Okay, or sometimes there is a direct blow. Suppose someone is hitting you with a rod and you just come to protect yourself. Then there is a transverse fracture of mainly one bone, usually of the ulna, which is known as a nightstick fracture. This is a very common MCQ question, so you guys should be knowing this. Okay. Next, on to the diagnosis. The diagnosis in case of any major trauma is mainly clinical. When the patient comes to you with the position of the limb, you will understand that this is a case of fracture of both bones, forearm. Okay. But to confirm diagnosis, we always do an X-ray. That's the most basic investigation in orthopedics. But one thing to keep in mind is the X-ray of the forearm that should include the views of both elbow and wrist. Okay, so that we can so that we do not miss any dislocation or subluxation of the proximal radial or distal radial joint. Lastly, coming to the treatment of the fracture of both bones forearm. One interesting thing is fractures of both bone forearm are considered intra-articular fractures. Okay, so what are intra-articular fractures? Intra-articular fractures are fractures involving any joint. Our forearm is considered a joint, starting from the proximal radioulnar joint, the distal radioulnar joint, and the interosseous membrane. Interestingly, the forearm also contributes some movement of movement. The supination, the pronation, supination of the forearm, it takes place in this forearm joint. Okay. As you can see, the elbow, it causes flexion, extension of the elbow joint contributes to, the forearm joint contributes to pronation and supination of the forearm. So that is considered a joint. And the highlighting factor of treatment of any intra-articular fracture is anatomical reduction, stable or rigid fixation, and most importantly, early mobilization. So these 3 points is to be kept in mind while dealing with any fractures of the forearm, or say any intra-articular fractures. Okay, so now starting off with what is the treatment often for fracture both bone forearm in the children. In children, we mainly attempt for closed reduction and cast application. So this is a bit contrary to what we just learned, that we need to go for stable fixation, early mobilization. But in children, what happens? The tough periosteum, children have very tough and thick periosteum as compared to adults. You must be knowing what is a periosteum. You've learned in anatomy, right? Yeah. So in children, they have very tough periosteum. So this helps to guide and control the reduction. Okay, and in children, the movement, it comes back pretty rapidly. So we don't have to wait for any joint stiffness or something like that. So that's why in children, the main method of treatment is close reduction of the fracture and cast application. That is to be kept for 6 to 8 weeks depending on the age of the child. But even in children, we sometimes need to go for operative fixation. What are the indications for the same? In fractures that cannot be reduced or the fragments are unstable. Okay, in those cases, due to severe injury of the periosteum, that splintering effect of the periosteum does not take place. So in those cases, we mainly go for close reduction under an X-ray, mobile X-ray in the OT, and fix the fractures with elastic intramedullary nails. As you can see in this picture, this fracture is already united. Okay, but this one was fixed, as you can see, with flexible intramedullary nail. These are known as 10 nail. Okay, titanium elastic nail. Okay. After children, there's another important topic to be learned, that's the green stick fractures. In children, the bones are not very brittle, they're more of like a stick of a young plant, those green sticks. What happens when you try to bend those sticks, break those sticks? They don't break, they bend rather, right? Same thing happens in case of a child, as you can see over here. What happens? There is breakage of only one cortex and buckling of the opposite one. Okay, as you can see, there's breakage of this cortex. The radial cortex is broken, but the medial one, there is only buckling of the medial cortex. Okay, so even the treatment of these fractures is different. What we need to do, we need to do a osteoclasis followed by cast application. So what is osteoclasis? This incomplete fracture, this angulated one, we convert that into a complete fracture. Okay, so what we are doing is we are converting an incomplete fracture into a complete fracture. Why? Because if we keep it like this, what happens is, due to union, there is callus formation on this side, but this side does not form any callus. So there is a incomplete union and incomplete growth of that cortex. That causes bending of the forearm. So we need to convert into complete fracture and then apply cast. Okay. Another important thing, in case of conservative management, always keep one thing in mind. Whenever you are facing a acute fracture, the patient has come to you with an acute injury, there is swelling, we do not apply a complete cast. What we do is we apply a half cast, that's known as a back slab. The plaster is applied to only one part, the other part is left open, that is covered by the cotton wool and stuff. Why is that done? Because in case of any acute injury, there will always be swelling of the affected limb. Okay, so again coming back to the topic of compartment syndrome. To prevent compartment syndrome so that swelling can take place, what we do is we apply a half cast, only a back slab. The other part is left open, only covered by cotton wool and the cotton bandage, so that the swelling can take place. Okay, after 1 week, when the chance of swelling has come down, then we convert it into a complete cast, that plaster thing that we do. Okay. Next, coming to the treatment in adults. For adults, that three things is to be kept in mind: anatomical reduction, rigid fixation, and lastly, early mobilization. Okay, so open reduction and internal fixation using plates and screws is a mainstay. Okay, bone grafting of the fracture part is sometimes required when if there is a comminution, that is, there is a multifragmentary fracture, or there is a loss of continuity of more than 2/3 of the circumference of the bone. And another indication is if there's a very old fracture. Okay, in these three cases we apply bone graft. Sometimes, most of the time, the bone graft is taken from the iliac crest. We take a bit of cancellous bone and apply there as a graft. Okay, so once again, very important point: early mobilization. Okay, and if you are facing an open fracture, that's a fracture with that has opened up, or there is a cut injury along with the fracture, what we do is we carry out a thorough debridement of the area. Okay, we remove all the dead, decaying and like dirt tissue from that spot, and then we apply an external fixator. That is, you don't apply any plate or screws, anything from inside. We apply an external fixator and allow the wound to heal. Only after the wound has healed, then we do the main thing, that is the fixation with plate and screws. Okay, so this is an X-ray of a fracture in adult being treated by plates and screws, as you can see. Sorry, this is the fracture site. It isn't fixed using plates and screws. There is a very rigid fixation, and so we can pretty well allow early mobilization of both the elbow and the wrist joint. That will help in preventing any stiffness of these joints and also allow the bone to heal very easily. So I think we have done the topic of fracture union, right? So you know that there are two main types: primary and secondary callus formation. So since it's a rigid fixation, what kind of callus will be forming over here? Secondary callus takes place in case of like not very rigid fixation. that is the main callus that you see. This is primary fixation, primary callus formation. Okay, so we don't see that huge bulk of callus, but the fracture unit takes place very smoothly. Okay. Next, coming to the complications. Whenever studying any kind of fracture, complications are very important to be kept in mind always. The early complications are nerve injury, visceral injury, vascular injury, sorry. As we were discussing, we need to always check for that while checking any patient of trauma, whether along with fracture there is any neurovascular injury. If there is any, we need to intervene immediately. Okay. If there is any vascular injury that warrants immediate intervention so that the limb is not lost. And in case of nerve injury, we can wait for some time because in most of the cases that's neuropressure that will like heal automatically. And lastly, the most important thing that I'm repeating multiple times, compartment syndrome. Okay. And as far as the late complication are concerned, delayed union, non-union. Okay. So what is delayed and non-union? Delayed union is when the fracture union is taking place at a rate that is slower than expected. Okay, but still the union process is going on, but at a slower rate. And what is non-union? In case of long bones, when the fracture is not united at 9 months post intervention or trauma, that is called non-union, or after 3 months of any consecutive X-rays, if we don't see any particular callus formation, that will be termed as a non-union. Okay. Next, coming to malunion. What is malunion? Malunion means the fracture is united but is not united in a proper anatomical position. Okay, that is malunion. And lastly, complications related to implant and implant removal. While putting in an implant, we might injure a nerve. While taking out an implant, we might cause fracture to the bone. So these are the late complications of fractures of both bone of forearm, which is the radius and ulna. Okay. Next topic is Monteggia fracture dislocation. Okay, so what is Monteggia fracture dislocation? This is a fracture of the shaft of ulna. It's mostly proximal shaft of ulna, along with dislocation of the proximal radioulnar joint. Okay, so 2 points: fracture of proximal part of shaft of ulna and dislocation of the proximal radioulnar joint. So naturally, the radiocapitular joint is also dislocated, as you can see in this X-ray. This head of radius, this has gone volarly. Okay. So this is the classification, Badow's classification of Monteggia fractures. As far as classification, there are 4 types of Monteggia fracture dislocation. The first type is in which the fractured ulna is apexed volarly, along with volar dislocation of the head of radius, the type 1. Okay. The second one is there is dorsal angulation of the ulnar fracture along with posterior subluxation of the head of radius. The third one is radial tilt of the angulation of the fracture shaft of ulna along with lateral subluxation of the, it has gone lateral, as you can see the radial head. Okay. The last one is fracture of both bones in the proximal part along with dislocation subluxation of the radial head. Okay. So there are 4 types of classification in this Badow classification type. Okay. Next, come to the clinical features. Once again, since there is a fracture, there will be a history of trauma to begin off with. There will be obvious ulnar deformity which will be visible, and tenderness, and also there will be tenderness and swelling of the radial part of the elbow. Okay. And the supination of pronation of the forearm will be severely painful and restricted. As we were discussing, forearm is a excuse me, it's considered an intraarticular fracture. So due to that fracture, the supination and pronation and also the proximal radioulnar joint is dislocated. You can see over here. So any kind of pronation supination will be severely painful and restricted. So next, from the diagnosis, once again X-ray. But as we were telling previously, it is very important to go for both AP and lateral views, including the elbow and wrist. As you can see in this AP view, this radius seems to be more or less in position. But once we take the lateral view, we see that this is dislocated anteriorly. So here comes the important, including both the views, AP lateral, including both wrist and elbow. Okay. Next, on the treatment, the principle of treatment of this fracture is to restore the length and proper angulation, proper bowing of the fractured ulna. Okay. Only then can we put back the dislocated radial head. Okay. In most of the cases, once we have properly reduced the fractured ulna, that bowing and length is maintained, the radial head comes back to its normal position on its own. But in many of the cases, this does not happen. So in those cases, what we do an open reduction of the radial head and keep it in position by Parkinson pins or something like that. Okay. So this is, as you can see, the next ray of a Monteggia fracture being after having been fixed with a plate. Okay. So this radial head, this was over here, it has come back to its normal position. As you can see, the length of the ulna has been maintained and also the proper bowing of the ulna. Right? The last type is Galeazzi fracture dislocation. So what is a Galeazzi fracture dislocation? Excuse me. It is a fracture of the distal part of shaft of radius along with dislocation of the distal radioulnar joint. Fine. Monteggia was fracture of the proximal shaft of ulna along with dislocation of the proximal radioulnar joint, and this is a fracture of the distal part of shaft of radius along with dislocation of the distal radioulnar joint. Okay. So again, the mechanism, it is mainly caused by a fall on outstretched hand with superimposed rotation force. So when you are falling with a outstretched hand and there is a rotational force that causes fracture of one bone and dislocation of the radioulnar joint. Next, coming to the clinical features, once again, history of trauma. You have to remember it in any answer you have to write down. First thing you have to ask is history of trauma. This is more common than Monteggia. There is prominence and tenderness of the lower end of ulna. The dislocated ulnar head, it forms a prominence that we can palpate and even see. And also there is instability of the distal radioulnar joint. Sometimes what happens, the dislocation is not very pronounced, so it's very difficult to see it or palpate it, but there is always a instability of the distal radioulnar joint. When you try to ballot the two bones, there is positive ballotment, and this is known as the piano key sign. Once again, I MCQ question. Okay. And coming to the diagnosis, we diagnose this mainly clinically, as with any kind of trauma. But to confirm the diagnosis, we get an X-ray done. Once again, true AP and lateral view of the affected wrist is required so that we don't miss the fracture. Lastly, comes the treatment. Once again, restoring the length and proper bowing of the radius is very important. Only then the ulnar head will come back to its normal position. Open reduction and compression plating of the radius is done. And then what we do is we check in the OT X-ray whether the proper reduction stability of the distal ulnar joint has been obtained. There are three things which might be which might have happened. First is the distal radioulnar joint is reduced and stable, so we don't need any further action for that. The patient can be left with all the movements to continue. The next probability is the distal radioulnar joint is reduced but is unstable, so there is a positive ballotment, positive piano key sign. In that case, what we need to do, but it has come back to its normal anatomical position. In this case, what we need to do is, we need to immobilize the distal radioulnar joint either in a plaster cast, we do apply an above elbow plaster and keep the arm in proper supination, or sometimes we do a percutaneous pinning. That means we fix the distal radioulnar joint with the help of a pin or K-wire. As you can see in this case, it has been fixed with a K-wire. Okay. The last one is, if the distal radioulnar joint is irreducible, that means even after maintaining the proper length anatomy of the fractured radius, still the ulnar head is dislocated. In this case, what we do is we do an open reduction and fixation of the distal radioulnar joint. We need to open up the distal radioulnar joint, remove all the stuff that is preventing the proper reduction, put the ulnar head back into place and fix it with the K-wire. Okay. So I think this is mostly that everything that you need to know about fractures of forearm. The poor fellow must be in severe pain. Okay, pain, difficulty in any kind of movement of the affected limb. So what you need to do in that thing is apply a above elbow plaster slab, not a complete cast. In slab, what we do, We put the plaster from here to here, but only in one part of the limb. Okay, the other half of the limb is left open. It is covered by the cotton wool and the cotton bandage, so that in this case there is a severe possibility of severe swelling. Okay, yeah, to prevent compartment syndrome, we apply an above elbow slab initially. Then this fracture has to be operated. He is an adult. Okay, so in this case, those three things are to be kept in mind. Anatomical fixation. So what do you mean by anatomical fixation? There should be proper fixation. The alignment of the bone should be proper. The proper bowing of the radius ulna should be maintained. As you can see, that's a bowing of the radius ulna. Notice the bowing. This forms kind of a convex lens. Those of you who are interested in physics will be knowing it, right? This forms kind of a convex lens. So this proper bowing is to be maintained, and that is anatomical fixation and rigid fixation. So what do you mean by rigid fixation? As you can see in this X-ray, this has been fixed with plate and screws, right? So this plate and screws, this forms a very rigid fixation. This won't allow any kind of movement in the fracture site. Okay. So anatomical fixation, anatomical reduction, rigid fixation, and lastly early mobilization is to be initiated. That means the day after he is operated, you should be asked to start mobilization of the shoulder, every kind of movement from flexion, extension, abduction. Okay, every kind of movement of the elbow, starting off with the extension, flexion, and also the wrist. Okay, after a few days, when the pain has subsided, you will also be encouraged to start off with the pronation and supination movements. Because once we are done with stable fixation, rigid fixation, we are pretty sure that no matter what he does, this fracture will not move. There will not be a bit of micromotion in the fracture site. So this will unite by primary callus. So we can allow any kind of movement of the affected limb. So how that will help him? That will help him to get back to work faster. He will be able to join you guys faster. But one thing is to be kept in mind, he needs to protect his limb so that there is no further trauma. We won't ask him to come back to the ground the next day, obviously. That will take another 1 or 1.5 months till some callus is formed. But from the very next day, you can come to the class, albeit with the dressing. The dressing will be there. So you can come to the class, you can sit with you guys, you can go to the canteen. Okay, so he will be leading a normal life. And for people who go to office, they can even join their work, say after a few days. The next day is discharged. What we do usually in this kind of fractures, we discharge the patient on post-operative day 2 or 3. So we ask the patient that if he wants to go back to his desk job, he can do that pretty well from day 5 or 6. This patient, as far as I remember, he was around 30-35. I had operated on him in Kolkata. He was working in TCS most probably. Okay, so he had gone back to his office within 10 days of the surgery. Okay, though he had a dressing on, the suture was removed on post-op day 14, but he had joined office, was doing his job, and he was pretty happy with this. Okay, so that is also kind of both bone forearm fracture which need to be operated along with those early mobilization thing. Okay, any other questions? So this was a very short lecture class, I presume. So you guys can come up with any question, anything related to orthopedics, not only this topic. You have any interesting thought in mind, any questions in mind, anything? Acha, Daka. Yeah. Fracture of both bones, there is proper bowing is lost. Okay, so etate fixation korte hobe. Huh? See, KOR দিয়ে fix করা in this kind of fractures is pretty difficult. কেন? তুই KOR বলছিস নাকি elastic nail বলছিস? কোনটা বলছিস? KOR. See, KOR fixation is advised when যখন আমরা মানে KOR is it is elastic but this is not a very strong fixator. Okay, তো আমরা KOR fixation কখন করি? এই fracture even in children it is not advised because it's a fracture of the shaft. Okay, so what we need to do in this kind of fracture is we can do it with an elastic nail. যেমন এটা দেখছিস. Okay, this is not a KOR. This is not a KOR. Okay, this is a 10th nail, titanium elastic nail. Okay, you বলছিস? This is not a KOR. KOR fixation is done when you're fixing maybe a fracture of distal radius. ঠিক আছে? Then after reducing the fracture, if it's not there is not too much of dorsal comminution, then we can just keep it in place using 2 K-wires. K-wires, and then we need to apply plaster cast as well, because K-wire is not that strong to keep that in place. If we just apply K-wire and leave the patient moving, the movement collar that might break as well. Okay. And another thing, in case of children, if there is a supracondylar fracture, class okay. So you must be knowing supracondylar fracture holo fracture just above the epicondyles, right? In those fractures as well, in children, we fix it using K-wires. We put it back into position, then fix it using 2 crisscross K-wires. And then also we need to put a slab in place, because once again K-wire is not a very stable fixation. ওটা বলে টেনশন ব্যান্ড ওয়্যারিং, ফিগার অফ 8, ঠিক আছে? ওইটা আমরা কখন করব কি বলছিস? Clavicule it is not always done. Clavicule we mainly do this splitting, ঠিক আছে? Sometimes in distal clavicle it used to be done, but এখন in that case also we don't do tension band wiring. Tension band wiring is mainly done in case of fracture olecranon, okay, and in case of fracture patella, and sometimes in fracture of the medial epicondyle, medial malleolus. So one interesting thing since we raised the topic is, when do we do a tension band wiring? We do a tension band wiring when there is a fracture, where there is a distraction force acting, right? Yes, in patella. In patella, in case of the this olecranon fractures, there is a distractive force working, because the muscle is pulling it in this side and the normal inclination is to go in this side. Okay, so there is a distraction force working, and the mechanism of tension band wiring is, when you do a tension band wiring, what happens? We convert that distracting force into kind of a compression force. In what happens in tension band wiring? The wiring is done like this in figure of 8 pattern. Okay, so when this part is trying to pull it apart, that figure of 8 prevents the pull and converts the pulling force into a compressive force. Same thing in case of a patella. Okay, so then we do the tension band, that figure of 8 thing, tension band wiring. But in these fractures, the tension band principle applies in this as well. Whenever we are doing this kind of plating, as you can see, there is, in case of bowing, what happens? There is a distractive force acting in this direction, and this direction, right? Because there is a normal bowing of the bones of the forearm. So there is a distractive force acting in this direction. As you can see, we have stopped that force by putting the plates on those distractive surface. So the tension band principle is working in this as well, but the tension band wiring is not done in this case, because it is more cumbersome to do it. Okay, the principle is the same, but the mechanism is different. Achha, anything else? You're coming with pretty interesting questions. Few more, please. Paul. Yeah. Yeah, right. Very interesting question. What is asking is, once we are doing a plaster cast, right? In case of fracture, what is the proper alignment of the limb that is to be kept? Whether do we keep it in supination, do we keep it in pronation, or in mid pronation? Etar jonno we need to come back to this slide. This one. Okay. So as you can see, there is a supinator muscle acting in the proximal most part of the bones, and then in the middle part there is this pronator teres, and in the distal most part there is a pronator quadratus. Okay, so suppose there is a fracture of this part, this part, yeah, proximal most part. So in that case we need to keep the limb in supination. Why? Because since it is in the region of supinator, the supinator will try to pull the proximal part into supination, and if we keep the distal part in pronation, that won't be reduced. So we need to keep that in supination. If the fracture is in the proximal most part, we need to keep that in supination, right? Suppose the fracture is in this mid part. So in that case, this is also working to some extent, and even this pronator teres is also working. So those two muscles are combining and putting the limb in a mid-prone position. The proximal fragment. So to neutralize those forces, we need to put the plaster in a mid-prone position as well, so that the effects of these two muscles can be negated, neutralized. Then once again, if the fracture is in the distal part, Then due to the added effect of this pronator quadratus, the proximal parts tend to go into pronation. And then in those cases, the distal fragment, if you put it in pronation, that will be most of it kind of reduced position because of the neutralization of the forces. Getting the point? So in case of fractures, very proximal, full supination, mid portion, mid pronation, and distal full pronation. Okay, so during our UG days, how do you used to remember these things? We used to say distal for Dehi. Okay, Dehi means you're giving something. So pronation, more the distal the fracture, more Dehi, more pronation.